Hey guys, it's Carter. If you are in either my EMT or my paramedic program, you've probably realized that we don't have a dedicated lecture on medical terminology. And that's because we really think that you can learn this material at home by just reading the textbook and spending the time making flashcards to learn these terms and the prefixes that you need to know to make understanding medical terminology easy. However, I do think that for some students there is some value in me spending some lecture time on this material. So if you feel like having some lecture time on the actual medical terminology unit would be helpful to you, this is the lecture for you. Now, if you're in my EMT program and you've really been paying attention to our curriculum and our slides, you might notice that these slides look a little bit different. And that's because these slides are coming from our paramedic program curriculum. I decided just to do one lecture that will cover both our paramedics and our EMTs because at the end of the day, the medical terminology stuff is the same. Whether you're a nurse, a physician, a respiratory therapist, a paramedic, or an EMT, we all use the same vernacular or vocabulary. And so either way, this is going to be relevant to all levels of EMS provider. If you remember back to our introduction lectures on EMS, you'll remember that the National Highway Traffic Safety Administration, or the NHTSA, is responsible for setting the curriculum and standards for emergency medical services in the United States. A part of their duties is setting the curriculum standards for EMS education programs, and that's what we base our education programs off of. One of the standards in the competencies is that students understand medical terminology. And the rationale they give is that if our students in EMS don't understand medical terminology, they're not going to be able to adequately interact with other healthcare professionals. That's really the reason you need to know this stuff. At the end of the day, all EMS providers are, say it out loud, patient advocates. And you won't be able to adequately advocate for your patient if you can't communicate with proper terminology what you believe the problem the patient is experiencing is. So that's why we teach this, and that's why learning this is important. To have a good understanding of medical terminology, you really don't need to have taken a specific medical terminology class, although that might be helpful to you. At this level for EMS, we really just need you to have a working understanding of medical terminology so you can understand what patients or healthcare providers mean when they tell you about a patient's medical history, they describe assessment results or assessment findings to you, they explain treatments the patient may have been receiving, as well as the patient's outcomes of the treatments or the tests that they have been undergoing. So the educational objectives for this chapter, if we really were to break them down, kind of break down into three parts. You need to know the origin of medical words or the origin of medical terms, so where they've come from. You need to be able to understand their components, and then you need to understand the guidelines for kind of putting those components and words together so that you can adequately communicate. If you can't communicate these terms, or if you don't understand what someone is saying to you, you can really lose people's trust and confidence in your abilities quickly, even if you are a very competent provider. For instance, if a patient has been diagnosed with a oligodendroglioma, which is a type of brain cancer, and they give you that diagnosis, what the patient probably isn't thinking about when they share that part of their medical history with you is that you don't specialize in brain cancer. You probably don't know what that is. But to them, that's the most important diagnosis in the world because it is a life-changing diagnosis for them or their loved ones. And so if you walk into that scene or hear that medical history and you don't understand what that diagnosis is, you can very quickly put yourself in a position where you've lost credibility with the patient and their family. Because we can't possibly expect you to memorize an entire dictionary's worth of medical terminology, what we're going to do instead during this lesson is give you some key terms, some acronyms, some symbols, and some abbreviations that you need to know so that you possess some basic skills to interpret medical terms. Now, of course, you're going to know a lot of medical terms by the time you complete your education program. But there's still going to be medical terms that you're unfamiliar with, or maybe that you've never even heard before. Maybe they're used infrequently, or maybe they're highly specialized and they're a part of medicine that we don't really see very often in EMS. Either way, having kind of this foundational knowledge should put you in a position where you can understand and interpret that information. Having worked in several jurisdictions and several states as a paramedic and registered nurse now, one of the things that I've noticed is that even between hospitals, people kind of have their own facility or regionally specific slang terms or accepted terms or even kind of prevailing vernacular or vocabulary for certain items. And if you think about it, that's actually true for things outside of medicine. If you go to the West Coast, nobody calls pop pop. They call it soda. But if you go up to the Midwest, what does everybody call Coke or any sort of carbonated sweet beverage you'd get from the 7-Eleven? Well, they call it pop. We mean the same thing. It's just a slang term, but it's used differently in different areas and jurisdictions. So we're going to kind of teach to national standards here that you need to know, but just be aware that some of the language and especially some of the abbreviations that you might be exposed to in your clinical exposures may not necessarily be 100% correct. So just make sure whenever you learn a new term or you hear something that you're unfamiliar with and you sit down and you look it up, keep in the back of your mind that you should kind of explore or just verify whether or not that term is kind of a slang or regionally specific term, or whether that's a term that's widely accepted and used within greater academic medicine. One of the best things you can do to expand your vocabulary and enhance your ability to understand this stuff is download a good medical dictionary. I believe Jones and Bartlett, the maker or the publisher of our textbooks, has an app in the App Store that you could use for medical terminology. Honestly, though, find an app that you like and use it to look up medical terms. One of the rules that I've always kind of enforced on myself personally as a provider is that whenever I hear a word that I'm unfamiliar with, or whenever I see a drug that I'm unfamiliar with, I write it down and I take time to look it up and learn it later. That's really enhanced my ability to understand different medical terms and also to really be familiar with medications that I don't see very frequently. The ancient Greeks were one of the first people groups to produce medical literature. And because of that, a lot of diseases and disease processes and even symptoms find their roots in Greek language. Now, the first time that we really began to dissect the human body was during a period in history where the most learned people spoke Latin. And so because of that, a lot of the anatomic structures are derived from Latin words, and so have Latin roots. Now, if you speak Greek or you've taken Latin at some point in your life, you are probably going to find that this stuff is a lot easier. I know everybody thinks that I've had way more schooling than anyone sane should, but I will confess that I have actually taken some ancient Greek in college. I have a little bit under my belt, and I'll honestly tell you that that has helped me significantly in my ability to understand medical terminology. But I want to emphasize that you really don't need to have that to be successful here. We're going to give you some tools to help you understand these terms. You don't need to sit through a Latin or a Greek class to be successful. So this is just a chart that kind of illustrates the relationship between some of the Greek words and diseases and Latin words and anatomic locations. And each kind of row there corresponds to a certain area. So if we take the third one as an example, gloss or glosso in Greek refers to the tongue. Refers to the tongue. So glossitis would be a inflammation of the tongue. Now in Latin, lingua means tongue or linguistic. What you'll notice here is that if you've had like one of the Romance languages like Spanish, you might notice that there are also some words here that have some overlap. So like lingua in Espanol means language, which actually corresponds to linguistic, the meaning of lingua in Latin. Either way, though, you don't need to know a foreign language to be good at this stuff, I promise. Another common way that we've given diseases or structures names in medicine is naming them after someone who discovered them. And I mean, it kind of makes sense, right? I think if I ever discovered a planet or some other major discovery, I think I'd kind of be hard-pressed not to name it after myself. So some of the famous physicians or medical researchers and scientists have actually had some of these diseases or disease processes named after themselves. And those are called eponyms. An eponym is when something is named after the person who usually discovered it. Just one thing to take note of when we talk about eponyms is that sometimes the correct pronunciation or the correct term is possessive. So an example of that would be Hodgkin's disease or Hodgkin's lymphoma. In those cases, the correct name of that disease process is possessive, Hodgkin's. It is his disease or his lymphoma. The incorrect term would be Hodgkin disease. We don't call it that. We call it Hodgkin's disease. In this case, it's possessive. Just like we call ALS or Lou Gehrig's disease, we don't call it Lou Gehrig disease. It's another example of a eponym that is possessive when we speak it or use it correctly. And these are just some examples of eponyms that we've seen. You're probably familiar with some of these, like the Apgar score, Crohn's disease, cesarean section. You may not have even realized that some of these terms were eponyms, like the Foley catheter. How would you like to be named that guy? Now, another common issue or problem, just sticking point that you'll need to kind of keep your eye out for as you go through this are homonyms. These are words that are pronounced almost the same way. An example of that is dysphagia versus dysphagia. Dysphagia is a difficulty swallowing a liquid, including saliva, which obviously places the patient at a higher risk for aspiration, versus dysphagia. Dysphagia just refers to a difficulty expressing oneself with speech. In those cases, very, very similar pronunciation, but very, very different treatment implications for how we ought to be monitoring and treating that patient. In these cases, incorrect pronunciation could lead to very serious medical errors. And so it's important, if you're not sure what someone else is saying, that you clarify, or you just ask them to explain what they mean. Remember, at the end of the day, we are here to be patient advocates. I really don't mind if the doctor thinks that I'm a silly or maybe incompetent person. I'm more worried about knowing that I'm going to be able to treat and transport the patient safely. So if it comes down to it that I need to ask the doctor to clarify whether he meant dysphagia versus dysphagia, I am more than willing to do that for the safety and welfare of a patient. If you remember back from junior high or elementary school grammar, you'll remember that an antonym is an opposite. So it's a word that has an opposite meaning. Here we have kind of a chart that lays out some common antonyms we'll see in healthcare. An example would be like you, a prefix, which means good, versus mal, which means bad. Example of you would be like eustress or good stress, and mal or mal would be like maladaptive or not a good way of adapting to a situation. Now, opposite of antonyms are synonyms. Synonyms are words that have a similar or the same meaning. Most of the time they're just a similar meaning. They're not exactly the same. So the first example that we see here, pulmon or pulmono means the lung, and pneumo also refers to the lung as in pneumonia. Now, as we begin to prepare to look at some actual medical terms, one thing to keep in mind is that medical terms are usually words that are made up of multiple parts. And so sometimes you can infer the meaning of a word if you understand the parts of the word that are kind of being put together to create this new vocabulary word. So there's four basic components that make up most medical terminology. There are prefixes, suffixes, root words, and combining vowels. Prefixes are so they come before. They are attachments that we add on the front of a root word. Suffixes are parts of a word that we add on to the end of a root word. The root word is the actual root word or the root term, and then combining vowels help attach prefixes and suffixes to the root word. You have to be careful here because changing or deleting any portion of a medical term can alter its content or alter its meaning. An example is there's a big difference between asystole and systole. Asystole would mean without contraction, and systole means contraction. So describing someone's heart as systole versus asystole is essential because we would be talking about two different types of presentations. Now, one thing to note is that not all words have a prefix and a suffix. Sometimes we'll just have a root word that has a prefix or a suffix on it. An example of that would be cutaneous versus subcutaneous. Cutaneous refers to the skin or the cutaneous layers, and subcutaneous would be referring to below the cutaneous layers. In this case, we have the same root word, cutaneous, which actually can stand by itself and be a valid medical term, or we can be adding a prefix to it, subcutaneous, which modifies what we're talking about. So far in the course, you've actually been engaging with root words that have prefixes, and you may not have even noticed it. One example is hypovolemia. We have hypo, which means low, plus the root word volumen, which refers to volume, and then a suffix emia, which refers to blood. So we literally have three different pieces here that come together to give us the word hypovolemia, which means exactly what each of those phrases or each of those pieces put together would mean. Hypo means low, volumen means volume, and emia means blood. So what does that mean? Low volume of blood. Hypovolemia, low blood volume. Another example of that is hypoglycemia. I'm sure most of you have heard of that at this point, or have heard of that term by this point in your course. Hypo means low, glyco or gluco means sugar, and emia, if we go back to hypovolemia, means blood. So hypoglycemia is referring to a low amount of sugar in the blood. So see how just understanding some really basic prefixes, suffixes, and root words can allow you to understand a new medical term that you maybe have never heard before, but instead of having to spend the time looking it up, you could usually infer the meaning of that medical term if you have a baseline understanding of medical vocabulary and prefixes and suffixes. Now, another type of prefix you may see is a numerical prefix. It is a numerical prefix, is exactly what you would expect it to be. It is a prefix that indicates numbers. So we can have uni or unilateral, which refers to one side of the body. You may also see, here they give you an example of monocular vision. So what do you think monocular means? Well, it means one-sided. So in that case, they would have one or one-sided vision. Now that we've talked about prefixes, let's kind of talk about the opposite, or what we add to the end of medical terminology, which are called suffixes. Suffixes usually appear at the end of words, and generally they can indicate procedures, conditions, diseases, as well as give us an idea of the part of speech of the word. So lip means fat plus ace. Lipase. Lipase is an important lab value. That tells us how well the pancreas is breaking down fats in the body. Now that we've talked about prefixes and suffixes, let's talk about the root word itself. So the root word is kind of the main root, or it's the stem that gets a prefix or suffix added to it. Usually the root word is referring to a body part. And so in that way, it's kind of easy if you understand what body part that root word is referring to, you can usually infer the general meaning or what someone is talking about when they use a vocabulary word that's unfamiliar. Now, as we've already discussed, you can change or modify the meaning of a vocabulary term by adding a prefix or suffix. But one other thing to just consider if you're trying to look at or understand what a new vocabulary term means, you should really try to look at the word in context and try to understand the word based on the context you're getting it in. So obviously, if you are hearing about a diagnosis in a cancer patient, you should probably be thinking something along the lines of cancer. Now, you're going to see these charts, and you're going to start to see more of these charts. They're also in your textbook, whether you're a paramedic student or an EMT student. And I'm not going to spend a whole time on these tables. What you should be doing on your own is creating some flashcards, though, so that way you can learn these root words and their definition. I think what you'll find is that you'll be able to see now how some of these words that we've been using in class, like cyanosis or cyanotic, actually make sense once you understand the root words, like cyano. Now, with vowels, there are combining vowels that can be used to join a prefix and a suffix. Honestly, I kind of feel a little silly getting into combining vowels because I feel like we're getting into the weeds of grammar. I don't really think that this is going to be super helpful to you. What you should really know, though, is that sometimes to connect a root word and a suffix or prefix, we will need to have a combining vowel so that that word makes sense or doesn't sound funky. And this slide just demonstrates an example of a combining vowel, like the word gastromegaly. The root word is gaster, but gastermegaly doesn't really make any sense. There's not enough vowels in there. So the way that that word has been modified is gastromegaly, which refers to an enlargement of the stomach. Now, one thing that I did want to add here is that if you understood that gaster or gastro refers to the stomach, and megaly refers to an abnormal enlargement, even if you had never heard the term gastromegaly before, you should be able to infer that refers to an abnormal enlargement of the stomach because you understood that root word and that suffix. So if the suffix begins with a vowel, a combining vowel is usually not needed. So gastric, obviously, doesn't have a vowel on the end of it. It ends in a consonant, C. So in this case, we change it to gastro so that we can use the word gastromegaly because gastric megaly would not really sound right and doesn't make any sense. And that's just not how this language and vocabulary has developed over history. I'm not going to really spend too much more time talking about the guidelines for combining vowels. If you'd like to read through these slides, you're more than welcome to, but at this point, I'm just going to move on. Compound words are distinct from words that we've added a prefix or a suffix to, because in compound words, we actually have two root words that are combined together to give us a meaning. So the example that they're giving you here is osteoarthritis. Osteo refers to bone. Where else have you heard of the word osteo? You may have heard of it in osteomyelitis. Of course, in osteoarthritis here, and here in arth. Ar refers to joint or joints, and itis refers to inflammation. So osteoarthritis is inflammation of the bone joints. Now, depending on the word, there may be a more accepted way to make that word plural. An example is I grew up in the Southwest where we had cactus everywhere. There was a cactus, there still is a cactus in my grandparents' front yard. There's a cactus in my mom's front yard. They're everywhere. But when we talk about cactus plurally, cactus is actually a singular cactus. It is one organism, is a cactus. If we wanted to talk about a plural of cactus, we would actually change the ending. We wouldn't say cactuses, we would say cacti. We would change the ending to a vowel. So, in some scenarios, in kind of these Latin or Greek terms, instead of saying is, which would just sound funny, people are going to look at you weird if that's how you're speaking. We instead change the end to a vowel. And here's kind of a chart of how sometimes that is changed. So, vertebra to vertebrae instead of vertebra isses. I don't even know how you would say that. It doesn't make any sense. We don't say anything other than vertebrae when we want to talk about multiple vertebra. Now, another key to be able to understand or speak and really communicate well is understanding topographic anatomy. And so topographic anatomy is the study of the kind of these superficial landmarks that we can see on the outside of the body that kind of guide us to the locations of the organs and vital structures that are beneath them. An example of that would be if you understand where the upper left quadrant of the abdomen is, you should also understand that that is where the stomach kind of sits and then where the stomach goes into the intestines. You should also understand that in that area of the body, maybe a little bit superior to that, is where the spleen sits. When we discuss topographic anatomy, we assume that the human or the person that we're discussing is in the anatomic position. So what is the anatomic position? Well, it is the person standing upright with their palms facing towards the front. And so what I mean by that is their palms are facing in the same direction that their face is, and their hands are open. There's also some planes and axes that you should know. I'm not going to spend too much time here discussing this because you've probably already had this, or at least I hope you've already had this in some of your anatomy and physiology. These planes and axis or axi are kind of just imaginary lines that we draw through people to kind of divide up the body so that way we can have an intelligent discussion about their anatomy. There are three main axes that we can divide people into, three main planes, so the coronal plane, the transverse plane, and the sagittal plane, as demonstrated in this graphic to the right. And there's kind of some deeper layers we can go into in these planes and axes. I'm not going to spend too much time here on it because my objective in this lecture is really just to cover the medical terminology. It's not really to give you a review of how we can divide up the human body. You've already gotten that in your anatomy and physiology lectures. You'll also need to know specific areas of the body that are kind of referred to. So here's a really good example of a term that can easily be understood if you understand the root words here, but you'd probably be pretty confused by if you'd never seen it before because it is so big. So the word here is sternocleidomastoid. Sterno refers to what? The sternum. Cleido refers to the clavicle, and mastoid refers to the mastoid process. So the sternocleidomastoid muscle is a muscle that runs from the chest up to the mastoid process in the head and helps to turn or rotate the neck. So here's a list of the specific areas of the body that you should be aware of. Honestly, you probably already know these terms. You may just have not really realized that you know this or have been really able to put these terms into this category. So we're trying to give you this category of terms that describe areas or locations in the body. You're probably already familiar with cranial. Cranial refers to the cranium or skull, right? And so a lot of these words, I'm not going to spend too much time here. I'm not going to spend time on each one. I would encourage you to generate a flashcard or study these however works for you. And this chart here is a continuation of that. Like I said, not going to spend a lot of time on it. So the body cavities are cavities in the body that contain organs and structures. So what are some body cavities we've already discussed? Well, we've already discussed the cranial cavity, which obviously contains the brain. We've also discussed the spinal cavity, where those vertebrae surround the spinal cord. There's a hole that runs down the middle of our vertebra, and that's what houses and protects spinal cord from trauma. There's also some body cavities like the thoracic cavity. And in the thorax, we have the heart, lungs, a lot of the great vessels, the thoracic. In the abdominal cavity, we have the digestive and endocrine organs. And then we also have the pelvic cavity, which honestly is something that I kind of think of as a cavity less, but it is truly another cavity in the body where we have a lot of the reproductive organs and some digestive organs as well. This is just a diagram of those cavities. I'm not going to spend a lot of time on this because I feel like it's pretty self-explanatory, but if you have questions, please feel free to reach out in the comments section, tag this section of the video, or send me an email. Now, we should also understand some basic directional terms because they tell us some things about laterality, whether we're talking about left side, right side, top, down, to kind of give us some idea of where exactly something we're discussing is. So, in terms of directional terms, we have anterior and posterior. Obviously, anterior means front, posterior means back. Superior is nearer to the head, and inferior is further away from the head. So, this, once again, is something that I'm not going to spend a whole bunch of time on. Really just something that you should kind of take the time to look at, read, and understand. Here is a list of some directional terms. Directional terms are almost always in pairs because they are opposite pairs. You need to be able to determine or to describe, something that's close to the center versus something that's not close to the center. And in those cases, we have lateral and medial. And we have two words that kind of describe each of those separate ideas because those ideas are both opposites of each other. So we have a separate term for each of those ideas or concepts that we are trying to convey in our communication. One thing that I'll note here about this is that this terminology is super helpful when you are trying to discuss or explain something via a radio report. For instance, if you're trying to describe where the patient's lower left extremity is deformed, there's obviously a difference between the superficial or deep tissue. So you could say that you see deep tissue exposed in the area of the open fracture, right, which would mean something different than if you just say, I just see some superficial tissue that's been lacerated. Additionally, anterior or posterior, back to my example here about trying to describe a lower left extremity deformity or fracture, you could say that there is deformity to the anterior surface of the calf, but the posterior surface appears to be soft and non-tender. Now, wink, wink, nudge, nudge, right, that would probably indicate that something had happened to the tibia instead of the fibula, because we have the tibia that runs on the anterior side of that lower left extremity. Now we're going to talk about some of these terms specifically. So superior is near to the head, inferior means nearer to the feet. Proximal versus distal. So proximal is closer to the trunk or closer to the core, and distal is further away from the trunk. So the elbow is distal to the shoulder and proximal to the wrist and hand. So if you think about that, right, it is actually true. And if you really understood these terms, you should be able to draw out that structure if you had never in your life before seen a upper extremity. Now, of course, it's not true, right? You're able to do that easily, but you could use these terms to describe perhaps where there was a stab wound or a gunshot wound. There is a upper extremity stab wound in the upper, that is proximal to the shoulder. Now I want to move a little fast through some of these other directional terms. Honestly, I just kind of see them as something that you're going to have to spend some time learning and reading through on your own. So I'm not going to spend a whole ton of time here. But if you have questions, things come up as you go through your reading, please feel free to reach out. Okay, so movement and positional terms. If you've ever done any sort of exercise or, if you've ever been to the gym and worked out, some of these movement and positional terms may be familiar to you already. Now, some of these terms, even though most people are familiar from the gym, they can be really helpful in describing a mechanism of injury to another healthcare provider. So here we have extension and flexion, or abduction and adduction. Have you ever heard of a, elbow, a knee that was hyperextended? What does that mean? It means it was extended, or it was straightened past the point that it is naturally supposed to go. Now, you've probably heard of the term hyperextension. We actually just used it in the last slide. But there's also this term of hyperflexion, where the maximum flexion occurs. So there's hyperextension and hyperflexion. There's also supination and pronation. These kind of describe usually wrist injuries. Supination is turning the palms up towards the sky, and pronation would be turning that palm back down towards the ground. So if you think about it, right, you're actually probably already familiar with supine and prone, right? Supine means they're lying on their back, and prone means they're lying on their belly. Well, which way are they facing if they're lying on their belly or they're prone, right? They're facing towards the ground. And if they're lying supine, they're facing up towards the sky. There's also some rotational terms here for rotational injuries, like internal rotation or external rotation. I'm not going to spend a whole ton of time on these because these are really just terms that are flashcard terms. You just got to make some flashcards for them and learn their meaning. It'll also probably become a little easier as you gain some experience in healthcare and you begin to hear these terms used. Just make mental notes every time you hear any of these terms used, so that way you can go back and kind of review them and see how they're actually used within a healthcare text. Now, I've given this example before, but you should already know that we divide up the abdomen into basically 4 quadrants. In EMS, we really just talk about the abdomen in 4 basic quadrants: the left and right, and then upper and lower. So we have the left upper, left lower, right upper, and right lower. If you look at this chart, you can see that there are different organs inside of each of these quadrants. And so because of that, you should just kind of keep in mind where each of these organs are, so that way you can kind of discuss. And also just for your own knowledge, right, if somebody suffers right upper quadrant abdominal trauma, you should be able to think of and know what organs are in the right upper quadrant of the abdomen, so you can provide good care and get that patient to where they need to be. Example of the right upper quadrant, or why this is important, is you have some pretty vascular structures. You got the liver up there. What does the liver do? Well, the liver is, in a sense, kind of the body's storage place for some extra blood. So when the body goes into shock, the body can actually squirt some blood out of the liver to increase some of the circulating volume. But because the liver is so vascular, if the liver becomes lacerated or injured and starts to bleed into the abdomen, you can get some pretty massive hemorrhaging pretty quick. So that's why understanding these quadrants is important. You need to be able to understand the organs that are in them and then be able to infer the possible severity of an injury based on where it has occurred. Additionally, we run on a lot of medical calls as well in EMS, so if a patient is having left upper quadrant pain or discomfort, you should know that the stomach is up there, as well as the spleen, as well as some of the large intestine and small intestine. Now, in some scenarios, and actually this is usually more common for like nursing, actually, I wouldn't even say nursing. I'd honestly say it's more common amongst like the gastroenterologists, people who are really discussing the abdomen in great detail. You'll see that there are these 9 regions that you can divide the abdomen into. You should be familiar with these 9 regions. I wouldn't, kill yourself over learning them, but I would just make sure that you kind of have a general idea of each of these regions. Now, if you think about it, a lot of this shouldn't be that hard for you to remember, at least for 3 of them, because you have the lumbar region, right, which corresponds to the lumbar area of the spine. You have left and right. And then the periumbilical region refers to the region that is about the umbilicus, or the belly button. Down here you have the left and right iliac regions, which correspond to the iliac crests. So that should be pretty easy to remember. The hypogastric region is kind of the region as we get into the lower part of the abdomen and into the pelvis. Well, you should already know that hypo means below, so gastric region, that's kind of the lowest region of the gastric area. And then you have the left and right hypochondriac regions, as well as the epigastric region. And you've probably already heard of the epigastric region before because hopefully you've talked or heard about epigastric pain. Epigastric pain is usually pain that's caused by irritation in the esophagus because it runs right here through the epigastric region, or the stomach because a big part of the stomach lives here in the epigastric region. Already kind of been mentioned here, but we'll just hit on it real quick. These are some terms that refer to the positioning of a patient's body. So prone, supine, Fowler, or semi-Fowler positions. Hopefully you've already been familiar with these because we've talked about how to position a patient on the stretcher or how to describe their position for our documentation. But please learn these terms, make flashcards out of them. Another position or term that you should be familiar with is the recovery position. This is a position that we place people into to help prevent them from aspirating when they don't have great control over their ability to protect their own airway. Usually we put them in the left lateral recumbent position. That's always kind of been the historic preferred position. And in the left lateral recumbent position, we're putting them up on their left side so that their head is kind of pointed down towards the ground and gravity helps us clear their airway. So let's talk about these positions for a second. How would you describe this patient's position who is right here? So this one in the left side of the screen there, how would you describe her position? So she's in the Fowler's position because she's really sitting upright at about a 90-degree angle with her legs extending forward. Now this patient in the upper right-hand side of the screen, right here, she is supine. She's lying on her back, she's facing up. This patient right here in the middle screen is in the prone position because she is lying face down. And then over here in the bottom right hand side of the screen, what position is she in? She is in the left lateral recumbent position, or the recovery position that we just discussed in the previous slide. We're almost done with this lecture, and we would be remiss if we didn't talk about some of the shorthand that people used to describe or type or write up run reports that kind of use these terms. You know, back in the day, everybody used to write things on paper. All run reports were done on paper. And so to kind of save space and save time, a lot of people and a lot of services adopted some symbols and abbreviations that were kind of universally understood. Now, one thing that you just have to be super careful of is if you're going to use symbols and abbreviations, you need to make sure that they are universally understood. I have found that EMS, we kind of use some abbreviations and some symbols that actually other healthcare professions really don't use, and so it can be confusing to them if they are trying to decipher or understand your run report. So this point right here, do not trade speed for accuracy, is super important. Please don't try to be fast if you're going to be inaccurate. It's just better to write out the actual term, the full word, whatever it is, instead of trying to use an abbreviation or a symbol if there's any question in your mind whether it will be understood by future readers. Now, acronyms are also commonly used. Probably the most common acronym we hear all the time is EMS, which stands for Emergency Medical Services, right? And that's what we do. But there's also some other acronyms like PD, short for the police department, USAR, Urban Search and Rescue. So some of these are probably going to be pretty widely understood. You should just be careful and make sure that whatever you're abbreviating is an actually accepted abbreviation within whoever you're trying to communicate with. So an abbreviation turns into an acronym if we pronounce the abbreviation as a word. So USAR is a acronym because we pronounce it as a word. HIPAA is another common acronym, but an example of a word or an abbreviation that is not an acronym would be the DEA, because no one says DEA, right? We just call the Drug Enforcement Agency the DEA. Nobody kind of combines it into an acronym. Big thing, make sure that your acronyms and abbreviations are consistent with those approved in your area and system. Some systems have actually gone so far as to create a list of medical control approved abbreviations. If that's something that your system has, I'd strongly encourage you to read through it and make sure that you understand it well. If not, you can go online and look at the Joint Commission, JCO, which is the accrediting body that accredits hospitals in the United States, actually has a list of abbreviations that are prohibited from use within hospitals. Now, EMS services don't really need to abide by that. However, it is a really good baseline tool because if the hospital is not allowed to use it, chances are you probably shouldn't be using it either. And if you do use something that's on that JCO prohibited acronyms or abbreviations list, you may end up just confusing the hospital with what you mean, because if they haven't been using it, chances are they're not going to be familiar with it. Another big rule is to never put a naked decimal or to use trailing zeros. So an example of that would be 4, units versus 4.0 units. Even though in some circumstances the prescriber could write for 4.2 units of insulin, if the prescriber just wanted to write for 4 units of insulin, they would just write 4 units. Okay. I actually recently read about a nursing home that was committing a medical error because when the prescriber wrote for a medication, it was actually insulin. The prescriber had meant to write for just 4. But when he wrote it, he wrote 4.0, but his 0 was just a little too close to the decimal. So when the staff read that, they interpreted it to be 40 units. And needless to say, there is a big difference between 4 units and 40 units. And obviously that patient experienced some hypoglycemic events because the incorrect dose of a pretty critical medication was being given to them. So for safety, it is not considered an acceptable practice to ever use a decimal 0 it's never considered an acceptable practice to use a decimal 0. Now, if you have some numbers after that decimal point, it is acceptable to use it. So like if we had 5.01 milligrams and that was an acceptable dose, then that would be okay because we don't have a trailing or naked 0. But if we were to just write 5.0 milligrams, that would be considered inappropriate because we have a naked 0. One other thing to keep in mind is that we never use a decimal and then a number by itself. We always put a 0 in front of our decimal to make it very clear that we are writing a decimal number out. You think about it this way, if we did this and maybe our decimal was too close to our 0, this hopefully would raise some eyebrows or some attention in documentation because this is not a normal way to write for a medication dosage at all. So hopefully people would be able to infer or contact that provider on what they intended to mean when they wrote 0.5 milligrams, right? Because that doesn't make any sense. They probably meant 0.5. Symbols are less common nowadays because they're not as easy to do on a keyboard. If you've ever tried to do symbols on a keyboard, you probably know that you have to hold like Control or Alt or Control or R or Alt at the same time and then like punch in some numeric code that produces, a symbol that's not standard on a keyboard. So, generally, you don't see symbols used that much. If you do end up writing a paper run report, there are some symbols that have been used, but generally speaking, if you're just used to writing, run reports using a text narrative, I wouldn't try to use symbols, even if, maybe for a couple runs your computer went down and you're going to have to write paper reports. Honestly, I wouldn't do it. It's going to cause you more time and effort to figure out what the acceptable or acceptable use symbols are. So just write out your run report using regular English language. So here's a couple tables of just some common abbreviations that are used. I think really the only abbreviations that I'll see used is this degree symbol up here. I believe on the computer, gosh, I do it so often. I believe it's Alt 248 is the code for it. But, I'll put, first or primary or second degree. But really, I think that's the only symbol that I frequently use. Like I said, though, if you're not going to be writing on paper, probably not worth it to be using symbols like this. There are some terms and just phrases, some things that are specific to pharmacology. We're not really going to get into that here. You'll get more of that when you are in your pharmacology unit specifically. Really, all I want to say here, though, is that if you learn the vocabulary in this lesson, you should be pretty well set up to handle the stuff that's going to come at you when we get to pharmacology later. These are some common prefixes and conversion factors that are used in medication administration. One thing to think about is in most of medicine, we're using the metric system now, but most patients are going to be familiar with the imperial system. So you should have an idea of how to convert some of those things back and forth, particularly temperatures and weights. Those are probably the two most common, imperial to metric, metric to imperial that we have to convert back and forth. You should also just know some of the breakdown of the metric system, that 1 liter is equal to 1,000 milliliters, and so on. On to our very last slide of this lecture here are just some terms, some prefixes, some abbreviations that are specific to pharmacology. Like I said, we're going to address this, more in greater detail when we get into our actual pharmacology units, but we do kind of want to expose you to these now since we do talk about medications and pharmacology quite a bit, and you'll be exposed to medications and pharmacologic interventions really even before we get into the specific pharmacology unit itself. So make sure you take a look at these and understand these. So this concludes our lecture on medical terminology. I hope that you found this helpful. If you have any questions, I would strongly encourage you to leave them in the comment section of this video. That allows everyone else who comes and watches this to benefit from kind of that shared learning experience. But as always, if you have a question that you would feel more comfortable just discussing with me personally, please also feel free to send me an email.